Hi everyone, my name is Dr. Priti Anand, and today we'll be discussing some important concepts about the oncology module. Starting with the small core, discipline provides the structure, focus sharpens the aim, so consistency fuels the journey to success. So please be consistent till your exams. Now, the first question is says that which of the following has the highest risk of ovarian cancer? We all know the ovarian cancer has a strong connection with the heredity, that is a family history. But remember, if the patient herself carries some mutations, then definitely she is at the highest risk. So, among all the cases, if we check the percentages, if the patient has two first degree relatives, or if the patient has BRCA gene mutations, BRCA1 positive mutations herself, the risk is very high. Okay. But as you can understand that if the patient herself carries the risk, she is at more risk than as compared to the family history alone. So the correct answer will be if the patient is a BRCA1 carrier. Now, if the patient is a BRCA mutation carrier herself and she has a positive family history, otherwise she is fit and healthy and completed her family. So, what will be your next appropriate advice to her? Okay. So, because she is a BRCA carrier and has completed her family, so the best advice will be to do a risk reducing surgery for her, right? For mutations, we always do a laparoscopic bilateral salpingo-oophorectomy. Okay. So, for these patients, we offer them bilateral salpingo-oophorectomy, preferably done when the family is completed. Okay. Now they sometimes ask you what is the appropriate age of doing. So ideally it should be done whenever the family is completed. But if earliest age they ask, it should be 35 years. They should ideally get it done. Okay. So these are the one question. Then the second question I've already told you that they ask the age. Now they even sometimes ask you that if the patient refuses surgery, what to do next. Okay. So BRCA mutations are some mutations in which you can, if the patient refuses a risk reducing surgery, you can offer them the regular surveillance. Okay. Offer them ongoing counseling and regular surveillance. And how is it done? It is done by doing a TVS every 6 months, starting at the age of 35 years or 5 to 10 years earlier than the first diagnosis of ovarian cancer in family. Okay. And by TVS and CA125 both, they are going to surveillance them. Okay. Now, because the BRCA mutations are asked in exam, similarly, the Lynch mutation carriers are also asked in exam. So, if the patient has a Lynch mutation carrier and she has family history of colorectal and endometrial cancer, she has completed a family and the vasectomy of the husband has done. That means the family has been completed. She does not want any more children. Husband has been vasectomized. So, what will be your further advice if she is a Lynch mutation carrier? Now, because the family is completed, the best advice will be to do a risk reducing surgery. Okay. So, prophylactic, not TAH, it will be laparoscopic hysterectomy. Okay. And because she's a young patient, you can basically the guideline says you can do it with or without bilateral salpingo-oophorectomy. But among all the options, the best option is bilateral salpingectomy. Okay, because Lynch mutations are also carries the risk of ovarian cancers. Okay, so at least if you are doing a salpingectomy, additional risk which is already there because of the tumors will be reduced. Okay, so it is plus minus salpingo-oophorectomy, but because it is not here in the option, so best option will be bilateral salpingectomy. And because she is 47 years old, so even in these patients, better will be doing a BSO along with the laparoscopic hysterectomy. But the mode of surgery will always be a laparoscopy. Okay. Similarly, at the same time, if the patient refuses surgery, then what needs to be done? Remember, for all the carriers of Lynch syndrome, according to the new talk, which says that the surveillance, they do not support any sort of surveillance. Okay. That does not improve the outcomes. So it is always better that they should undergo the surgery itself. Now, there is a patient who underwent cervical screening and it was severe dyskaryosis. So she was referred for colposcopy. Colposcopy showed that it was SYN3 changes. So they did a colposcopic directed treatment. That was a Leeds procedure. But unfortunately, when the biopsy came from the Leeds operation, the part which was taken, it came out to be stage 1A1 cervical cancer and there were SYN3 changes as well. But when they saw whether the margins were clear or not, they saw that SYN3 was still present on the deep lateral margins. So what will be your advice to her? Because SYN3 is present on deep lateral margins, they will always advise them re-excision. And this time it will be conization. Okay. So any patient in whom the Leeds operation is done and by chance the biopsy samples shows that it is stage 1A1 cancer, which is completely excised, we do nothing. Okay, if the SIN1, SIN3 and stage 1A1 are completely excised, margins are clear, we just put them on follow-up. 6 months, because it is cancer now, so frequent follow-ups. But first follow-up will be at 6 months. But if the margins are unclear, then what needs to be done? We need to check which margins are involved. If the endocervical and deep lateral margins are free of both SIN and the invasive disease, the gynecological cancer pathologist and MDT has reviewed the pathology, we don't do anything. Okay. But if the invasive lesion is excised but SIN changes extends to deep lateral and endocervical margins, then a repeat excision should be done. Okay, to exclude further invasive disease. But if SIN changes are present on the ectocervical margins only, then re-excision is not planned. Okay, so this is the way how it goes. Now, the next question says that there is a patient who underwent a routine smear of cervical dyskaryosis, and at the smear you found the endometrial cells, normal endometrial cells. What to do? And her age is 43 and her period was 10 days ago. Now, any patient in whom the age is less than 45, okay, if it is less than 45 or equal to 45 and the endometrial cells are found on cervical screening, then we do nothing. It is insignificant. We need not to report, we need not to tell her to go to gynec department. But if she was more than 45 and up to day 12 of menses, again it is insignificant. But if she is more than 45 and after day 12 of menses, preferably if she is not using CHCs, HRT, IUCD and tamoxifen, she requires a gynecological reference. So because she is 43 years old, the normal endometrial cells in smear is insignificant. So we do not tell her anything. We just call her for routine cervical screening as it is. Okay. Then if the patient has hysterectomy done for abnormal uterine bleeding, only hysterectomy done, and histopathology shows that the SIN3 changes are negative on the margins. They were present, but the margins are absolutely clear. The vault margins are absolutely clear of SIN3. What to do? Only one smear will be done after 6 months. Okay. Now, if the patient has negative margins, only one smear is done at 6 months. If negative, discharge. If positive, refer for colposcopy. If SIN3 changes are present at the margins which are incompletely excised or the margin status is uncertain, then if SIN1 was present, you follow up at 6, 12 and 24 months. If SIN2, SIN3 are present in the margins which are incomplete or uncertain, then we follow up them at 6 months, 12 months and then annually for 9 years to complete the full duration of 10 years or until the age of 65, whichever is later. Again, this flowchart is very, very important. This table, one question from this table every time comes in your exam. So another question says that a patient has hysterectomy done for abnormal uterine bleeding and histopathology was negative for SIN3. Now, whenever the hysterectomized sample has SIN changes and if the margins are completely negative, only one wall smear is done at 6 months. Okay. And if that wall smear is negative, patient is discharged from follow-up. If positive, we refer for colposcopy. But if the SIN changes are present in hysterectomized sample and you are uncertain about the margins or there is an incomplete excision. So if it has been SIN1 changes, you follow up them at 6, 12 and 24 months. If it is SIN2, SIN3, same process, 6 months, 12 months and annually for 9 years or till the age of 65, whichever is later. Okay. These are very important questions. One question, mostly they ask the questions related to this hysterectomized sample having SIN changes in your exam every time. So please be well prepared with this. Another question is related to HPV vaccine in 16-year-old girl where they're asking what is the correct statement. Okay. So both vaccinations administered in UK are quadrivalent. It's not like that. The bivalent vaccines are also given. The vaccination can be given in adult females from 16 to 25 only. So only is a wrong statement because less than 16 can also receive and more than 25 also. HPV vaccinations aim to target 6, 11, 16, 18, not 8. Two prophylactic vaccinations can be have been developed with aim to avert 90%. It is actually 99%. Vaccination is single dose, largely delivered at secondary school. So this is a correct statement because young patients can only receive single dose. Okay. The vaccination is a single dose largely delivered through secondary schools. Okay. So this is the correct statement because according to the new guideline, remember that all the females, okay, who are less than 25 will receive one vaccine only. And this can be given in the secondary schools also. Okay. And all the females who are Similarly, if it is a one shot Gardasil, Gardasil 9, Cervarix, anything which is given, it is given in a single dose. Okay. Uh, Two doses are only for the females who are 25 and above. Okay. And for the patients who are immunocompromised, the 3-dose schedule is given. Okay. So less than 25, single dose, more than 25, it is double dose. Okay. And immunocompromised, it is 3 doses. Now, if there is a patient who is an elderly female having vulval soreness and itching, there is a lesion which is seen at right labia minora close to the forehead. The distance of the lesion from the midline is 1.5, that is, it is a midline lesion basically, and no palpable nodes are seen, and it is a 1.6 millimeter depth and 1.5 centimeter lesion. Okay, so 1.5 centimeter lesion is stage 1A1, but because the depth is more, so it becomes a stage 1B. So stage 1B lesions are always treated with radical wide local excision, and because it is a midline lesion, so bilateral lymph node dissection will be done. Okay. If it was a lateral lesion, then unilateral lymph node dissection will be done, and if those lymph nodes are involved, then contralateral will also be removed. And if it was considering both the criteria, less than 2 centimeters in size and less than 1 millimeter depth of invasion, less than equal to 2 centimeter in size and less than 1 equal to 1 millimeter depth of infusion, then this is stage 1A, and irrespective of its location, only the radical bilocular excision is done. Nowadays, they also promote that there should be sentinel lymph node biopsies for the vulval cancers. So even sometimes you might get the options like that. So please look into it very carefully. Okay. So sometimes they ask you sentinel node biopsies also. So this criteria you should know. So if it is fulfilling a criteria, so you can even do without doing an excision, you can do a sentinel node biopsies. Okay. So these indications you should know. So the next question says that there is a 50-year-old woman with a large ovarian cyst and there is a 10 into 7 centimeter left ovarian mass, which is extending to the fimbrial end of the tube. Okay. Peritoneal washings were obtained and everything, full surgery was done. Nodes were negative and it was negative peritoneal washings with the mucinous cyst adenocarcinoma of the ovary. Okay. But can you see that the fimbrial end of the tube was involved? So definitely they are asking. So the spread of the ovarian cancer to the fimbria or to the fallopian tube is considered as stage 2A. Okay. Now, if the same patient, they are asking you the surgery has been done and what will be the post-operative management for this patient. Okay. So the same patient is there where the fimbrial end of the tube is involved. So it is stage 2A. So for the 2A, what do? We give them chemotherapy. Okay. And that is always a combined chemotherapy which should be given. Okay. For the very early stages of ovarian cancer, only surgery is enough. For the little later, stage 1A, 1B, grade 3 and stage 1C, all the grades, only single agent chemotherapy is given. But from the stage 2 onwards, always a dual agent chemotherapy, carboplatin and paclitaxel are given for 6 cycles after the surgery. So majority patients will undergo surgical staging. Okay. And after the surgery from stage 2 onwards, dual agent chemotherapy is given. Now, this is a patient who is a very young patient of 22 years old and has a right ovarian mass, which is a dysgerminoma. Unmarried. Okay. So what will be the treatment option for her? Remember, for the GCT tumors also, the standard is always a surgical staging. But when there is a fertility preservation required, they will undergo laparotomy with unilateral salpingo-oophorectomy because it is stage 1A, one ovary is involved. All the washings and biopsies will be taken. But remember, contralateral normal ovary will not be touched. Okay. So it will be a laparoscopic unilateral salpingo-oophorectomy. Peritoneal and omental washings and biopsies will be done. Okay. But contralateral ovary is not touched. Okay. Please remember. And it will always be a laparotomy, never a laparoscopy. If the persons with GCT undergo surgery, few early stages do not require post-operative chemotherapy. But if the chemotherapy is required, it's always a BEAP regime, bleomycin, etoposide and cisplatin. Okay. If the female is more than 40 years old, then only EP, etoposide and cisplatin are required. Okay, now this is a patient who is pregnant with stage 1B1 cervical cancer. So what is the appropriate management for these patients? For these patients who are very near to the delivery, for stage 1B1, they always say if it is more than 22 weeks, you can either give them neoadjuvant chemotherapy or delay treatment after delivery. Remember, she's at very close to the delivery. fetal maturity, because at approximately 34 to 36 weeks they will deliver these patients, preferably by cesarean section. So what you can do right now is to delay the treatment until delivery. If it was a very early stages, like more than 22, let's say 24, then you can start the chemotherapy after in the second trimester. If it was less than 22 weeks, then you first do a pelvic lymph node dissection. See if they are positive, you can offer them termination. If they are negative, then you can either do a delay treatment after delivery or at least start neoadjuvant chemotherapy. Okay, for less than 22 weeks, they always do a lymph node dissection. Positive, they can terminate, and for negative, very early stage, they can do simple trachelectomy. But for not for advanced one. Okay, so they will always try to do either a simple trachelectomy or delaying treatment after delivery. So it all depends. Okay. Now, if there is a patient who has undergone a hysterectomy for fibroid, considering that it was a fibroid, she was suffering from HMB, she underwent the surgery. But later in histopathology sample, it came out to be a sarcoma. Now, what will be her best imaging of choice? Remember, first thing is always an MRI scan, okay? Because we need to see the local evaluation we need to do, staging we need to do. PET CT and CT scans. PET CT definitely, if you suspect any distance metastasis, you will do. CT scan is chest X-ray, gives you you're not able to conclude chest X-ray because you find that there can be metastasis. Then CT chest can be done. But however, for abdomen and pelvis, the first thing needs to be done is an MRI scan. These are the references which are related to the same question. Now let's move to the EMQ questions. Okay, so the first question says, so the first EMQ question says that you have to choose a single most appropriate management from the list of options above. Okay, so always read this lead statement. So it is a cervical cancer, stage 1A1, no lymphovascular space invasion and completed childbearing. So for any patient with cervical cancer who has completed childbearing and is even at the very early stage, they always offer them simple hysterectomy. Okay, because it is a very early stage, lymph node dissection will be not done, and because they have already done a lymphovascular space invasion which is not involved, so lymph node dissection will not be done. Similarly, if the patient has 7 millimeter depth of invasion, okay, it is localized to cervix, the lesion is localized to cervix, but the depth of invasion is 7 millimeter. With excision clear, investigations, lymphovascular space invasion is no present, no lymphadenopathy is present, no metastatic disease is present. Okay. So she has completed her family also. Now, because of the depth of invasion, it becomes stage 1B1. Okay. Now, because it is a 1B1 cancer and completed family, the surgery will be radical hysterectomy and bilateral lymph node dissection. Okay. Apart from stage 1A1, everybody will undergo the lymph node dissection. Even on the imaging, if it is negative, you have to do it and prove it histologically. So for the patients who have very early stage cervical cancers, if they want completely their family, simple hysterectomy is done, no lymph node removal. Stage 1A2, modified radical hysterectomy, lymph node dissection. 1B1, radical hysterectomy, lymph node dissection. And if they want fertility preservation, it is only done till stage 1B1, which is radical trachelectomy. From 1B2 onwards, chemoradiation will be done. But from very early stage, for very young patients with stage 1B2 and second A1, surgical options can be offered. After surgery, you see whether they are at high risk or intermediate risk. High risk will receive after surgery post-operative radio and chemo. Intermediate risk will receive only radio. So now you can understand how much essential it is to properly stage them. Otherwise, we are protecting them from one thing that we'll do only surgery or we'll do only chemoradiotherapy. So if your staging is not correct, you will land up giving them both of them. Okay, more toxic to the patient. Another set of EMQ again says the single most appropriate answer from the above list. So there is a patient who underwent an HPV test which was positive. Her cytology was normal. So if you can understand that if HPV is positive, definitely cytology will show some changes. But if in case it is normal, what to do? So what we'll do, we'll call her after 12 months, repeat her HPV test. And if HPV test is negative, we send her for routine recall. Okay. If it is positive, we'll again do a cytology. If it is abnormal cytology, we send her for colposcopy. If it is again negative, we'll call her once more to do HPV test at 12 months. Now, after 24 months, by chance, if HPV is positive and cytology is negative, we send her for colposcopy. There is a patient who is diagnosed with SIN1 on 12, because SIN1 we only follow up, we do not treat. So on follow up, first follow up is always at 12 months. We call her HPV is positive, cytology shows changes, so they referred her for colposcopy, but colposcopy was normal. What to do next? So such patients in whom they are only on follow-up, or if they are treated cases of SIN2, SIN3, and their by chance HPV is positive on follow-up, cytology changes are there, but colposcopy is normal, what do? We call them at 12 months. Okay. What the guideline says that if patients have SIN1 changes, we recall them at 12 months, first follow-up. HPV is positive, cytology is done. If it is abnormal, we refer for colposcopy. Okay. And in case if colposcopy on follow-up shows that it is normal, we recall them at 12 months. Okay. This is very important question. Very many times it has been asked in your exam. Another question says that there is a patient for SIN3, leads was done, but the margins are not clear of SIN3. So remember, for any patient SIN2, SIN3, if the leads is done and margins are not clear, we always do re-excision, and preferably this time it will be a conization. Okay. But in case if the patient, like in this question, see the difference is in the age. Same question is there, but difference is in the age. Here the patient is 55 years, here the patient is 35 years. So 35 years lady in SIN3 was done and the margins were not clear. We are only doing follow-up, because if the patient of SIN2 and SIN3 are treated and margins are not clear, we do re-excision. But if the patient is less than 50, no invasive lesions and no glandular abnormality is there, we can put them on follow-up. Okay, so this patient is more than 50, we'll do re-excision. This patient is less than 50 and they have not mentioned about invasion and glandular changes. That means everything is okay. So we can call them at 6 months. Now, this patient we have just discussed. Yes. So, if this patient was SIN3 changes and leads was done, margins were clear of disease. So, if anything is clear of disease, remember any patient who is treated SIN2, SIN3, CGIN, first follow-up is at 6 months. Okay. This is different than what we have done. Here the margins were unclear of disease. Now here the margins are absolutely clear. So what is done? The first follow-up is at 6 months. Okay. Now at 6 months, if the margins are again HPV test is negative, what is the next follow-up? It is at 36 months. Okay. Remember, this is not a routine follow-up. This is a follow-up because the patient had a problem. So if the patient have treatment done for SIN2, SIN3, HPV test is done at 6 months. If it is positive, negative, we recall them in 36 months. Okay. Again negative, then we recall them at routine recall, that is 5-year recall now. Whereas if the HPV test is positive at 6 months, then we do cytology, but we always do cytology. But even if it is normal, we send them for colposcopy. And in case if colposcopy is normal, we have discussed earlier also, we call them at 12 months. So if the patient has leads done for SIN3, margins were clear at the follow-up of 6 months, HPV was followed for positive, cytology had changes, but colposcopy was normal. Again, you can see what we'll do. We'll recall in 12 months. Very, very important question. It has been asked in different ways in exam on the follow-up of SIN1, in the follow-up of SIN2, SIN3, which were treated. So it is always recall in 12 months if colposcopy is normal on any follow-ups. Specifically, if it has been a follow-up of SIN1 or treated SIN2, SIN3. 40-year-old woman had routine smear at community. The smear is reported as borderline squamous dyskaryosis and she was referred for colposcopy. Colposcopy was inadequate. What to do next? Okay. Now these are the routine recall patients. Okay. Routine smear was done. HPV was positive. So they went for cytology, which was borderline changes. So they sent her for colposcopy. Colposcopy was inadequate. Now here, what does the inadequate word means? That the full transformation zone is not visible. So what do? We again repeat colposcopy in 12 months. Okay. Because these were the low grade changes. But if it was a high grade changes and colposcopy was inadequate, we preferably offer them straight away the leads operation. Okay. So remember, this is again a very important question. So there is a 37-year female, routine smear, HPV was positive, followed by cytology, which showed a high grade changes. Patient was referred for colposcopy. Colposcopy reads endocervical cells, which changes suggested of CGIN. She underwent a excisional treatment, okay, but margins were unclear. What to do next? Now, if the patient has not completed her family, okay, so we can do a re-excision for the patient. Okay. So basically it is CGIN changes, still a pre-invasive changes, and CGIN changes with uncertain margins or in which the margins are unclear, always do a re-excision. Okay, it is just a pre-invasive. Now, irrespective of fertility, whether completed family, not completed family, so here because it is still pre-invasive changes, we can do re-excision. Okay. If the margins are positive, then re-excision is advised. But in case if the patient denies re-excision, then you can put her on follow-up. Okay. If both are clear, then on follow-up, then annually you have to complete the total of 10 years. That is 9 years more you have to follow up after 6 and 12 months. Okay. Now remember one thing, some patients in whom CGIN is present, excision have done and the margins are unclear and she has other problems like menorrhagia or anything which gives us a hint that she requires a hysterectomy. So look into that case that if she has completed family and she has other reasons for hysterectomy, you can offer her hysterectomy. Okay. Not always, but in case if it is there. Completed family and other reasons for hysterectomy if present. So if margins are unclear, you can even offer them hysterectomy. Okay. So CGIN treated, follow up at 6 months, negative, follow up at 12 months, negative, follow up at 36 months. And if they are positive at any point of time, you do cytology. Cytology, whatever it shows, but it is always refer for colposcopy. Okay. The same things which we have discussed earlier also. So please go through them once. Now this is a patient who had an endometrial cancer. हाँ sir, thank you. Now, this is a 52 years old lady where the endometrial cancer was done for staging laparotomy. Okay. Histopathological evaluation shows that endometrial cells are present. Endometrioid endometrial cancer is present involving uterus and less than 70% of the myometrial involvement is there. Microscopic adnexal involvement is there. They have ruled out as independent primary ovarian cancer. Molecular classification indicates pole mutations. Okay. Now, because here, if you can see, first of all, the pole mutations will never change the staging. Okay. These are required for the further management during the surgery or after the surgery. Okay. Now, because here you can see that the cancer has invaded more than 70% of the myometrial with adnexal involvement. Okay. So, more than 70% of the myometrial involved, and if there has been adnexal involvement, then we call them as stage 3rd A cancers. Okay, am I clear? Now, if you see what is the difference between 1A3 and 3rd A, because both of them has myometrial invasion, here adnexal involvement. So here in stage 1A3, there will be never more than 50% myometrial invasion. Okay, so remember that if there has been and you have any confusion, so always look that myometrial invasion should be less than 50. There should be no lymphovascular space invasion, no additional metastasis. Ovarian involvement is unilateral, limited to ovary and without capsule breach. Then it becomes stage 1A3. But if it is stage 3rd A where adnexal involvement is there, there will be, in addition, there will be more than 50% myometrial invasion. There will be lymphovascular space invasion. There will be bilateral ovarian involvement with capsule breach and additional metastasis may be present. Okay. So remember that how do we differentiate stage 1A3 and 3rd A1, because both have similar findings, adnexal involvement. Now, this patient has, if we were just talking about this, that histopathological shows that endometrioid cancer involving the uterus, ovary and cervical glands. Okay, here the glandular involvement does not mean stage 2, and because endometrial cancer is there which is involving the uterus and ovary, because nothing is mentioned, that means no news is good news. We can consider that everything is involved within limit, less than 50% myometrium, and the unilateral ovarian involvement is there, so it automatically becomes stage 1A3. Okay. You should know what is the aggressive and non-aggressive variety of endometrial cancers. You should also know the staging very well. They might ask you in the exam. Okay. Now we have to check the management option for endometrial cancer. Very important question. So always read the lead statement. You can see that all the patient had underwent the surgery already. Now they are asking you the adjuvant treatment for them. Okay. So 58-year-old, BMI 32, presents with stage 1A grade 1 endometrial cancer, less than 50% invasion, no lymphovascular space invasion, but pole mutations are positive. Okay. So it is already mentioned that it is stage 1A grade 1. Okay. Stage 1A grade 1 with pleural mutations usually require no adjuvant treatment after the surgery. Okay. That means surgery is more than enough for them. Okay. Because they have excellent prognosis. But at the same time, if the patient has stage 1B grade 3 changes, endometrioid variety, not a abnormal histology is not there. It is a normal endometrioid adenocarcinoma, non-aggressive variety. Deep myometrial invasion is there. No cervical involvement, substantial lymphovascular space invasion, and P53 wild type is present. Okay. Now, if you can see, there are too many problems in this. What are those problems? First thing, patient is more than 60. Second thing, stage 1B, grade 3 lesion, deep myometrial invasion, lymphovascular space invasion, and P53 wild type. So, whenever there is a P53 wild type, EBRT and chemotherapy 100% will be given. And because this patient fulfills more than one criteria, more than 60 years age and deep myometrial invasion and grade 3 lesion and lymphovascular space invasion, she will also require vaginal brachytherapy. Okay, so the answer will be vaginal brachytherapy, EBRT, and chemotherapy. Now, this patient is stage 1 endometrioid cancer, non-aggressive variety, grade 3, and no myometrial invasion and no lymphovascular mapping has been shown, no metastasis. So it is basically 62 years old, more than 60, stage 1 lesion, which is grade 3. Okay, so if you can see that surgery has already been done. So patients, because this patient fulfills the criteria, that is more than two of the following, more than 60 age and grade 3 lesion. Okay, because she fulfills this criteria, she will require at least vaginal brachytherapy after the surgery. Okay. So these are few things which I have added for your quick revision about the endometrial cancer. How do we stage them? What is the importance of the molecular staging? How is staging and the post-operative management done? So please go through these slides. They are going to help you in your exams. Okay. So thank you everybody. I hope this lecture helps to all. All the best for your exam. Study well. Be consistent till your exam. God bless you all and all the best from me and my team, StudyMEDIC. Thank you so much everyone. Thank you.